People still have only one type of classification, and what we talk more here is type A, which is the direct hole from the carotid artery into the venous drainage. But of course, traumatic injury at the region can be from the dural smaller branch nearby. Etiology are mostly a blunt injury in Thailand, it's decreased, but in other part of the world, maybe penetrating or iatrogenic injury. Think about if you have spontaneous or very minor, like sitting and falling down here, and you say, oh, you have direct CC fistula. Forget it. Think about this. You need to check underlying vascular or pathology, because for this kind of minor injury, it's never happened of this type A or direct traumatic fistula. You must have either FMD and F1 or the loss or others. Think about it. So, drainage. We were seeing all the possibility of drainage. So the most common presenting symptoms are the less violent one, which is ophthalmic veins. So the rest are more dangerous of the drainage. So relating to the drainage, most of the symptoms are related there. If you have this majority of the ophthalmic drainage, remember these symptoms can be the pulsatile tinnitus, drainage, post-ciliary. Of course, this is the eye symptoms. So for this case, you may have just beginning of this chemosis, proptosis, and bruit, but it can be worse and worse and worse. Usually we have patients who have bleeding from this down to the face, and depends on the severity of the congestion in your eyes. And if you talk about the drainage, back pyovenous drainage, think about this type of, venous congestion, even the bleeding inside the brain related to the pyovenous reflux that can be seen. Mass effect. Chronicity comes with mass from its size. So remember that this, for example, the case from Vietnam again, we have a good friend there. So you see the big pouch, one even extend above to affect the brain, and bilateral cavernous mass effect was there. And this is the angio that you can see how large the mass effect can be seen. Of course, the first cranial nerve to involve is the sixth nerve. It's medially located. We see later on third and fourth nerve. We don't see much. Actually, I see only one trigeminal one, which I was talking to Pia, why trigeminal nerve is not involved much in this mass effect. This is a ganglion, and it's strong, and it's probably not as close as the tree of the cranial nerve. So mostly 6, 3, 4. And the drainage, higher drainage. Look at this ugly looking pyovenous drainage, supra and infratentorial. It can be happening, and the symptoms can be, worse. The patient has changed his consciousness and start to have the bleeding over this venous congestion. Even you see this and you are reluctant to set the treatment of this case. Look, 5 days. For us, when you see pyovenous congestion, make it in 1 or 2 days. I will not come in the middle of the night with a pyovenous reflux. I just make it urgent, because this can be seen. And imagine if it's happened in post-severe fossa, you can easily lose the patient. That means you need to go back and study the possibility of venous drainage related between carotico-cavernous and it's the kind of mesencephalic veins of the region, and it even you can relate it drainage down to the spinal veins over there, and a lot of the possibility to relate it through the anterior lateral perimesencephalic veins by all these things. So not strange that you will have these symptoms related to this CC fistula that you can be seen with explained by all this possibility of the connection of the venous drainage, spinal vein drainage. Okay, can be rarely, it rarely presenting with spinal myelopathy. Strange, but maybe we treated before, but I don't have a single case. I have many cases of spinal vein drainage, but don't have a symptomatic one. This is the case that we will come in the middle of the night because you have CC fistula and there's a telephone call from your friend in the nearby ruins. Major car accident 2 weeks ago with now presented with massive epistaxis. It's like bleeding until shock, and then it stops. And then you resuscitate, you put water, you put blood, and it starts bleeding again like hell. So the recommendation is that pack whatever they can pack. They pack anterior, posterior, forelegs, whatever the material they have to pack, and send rapidly to us. So this is what we can see. You can see the clamp of the packing still there, and then you will try to treat and make the patient survive. This is a rare case that you have extended venous pouch with the dural tear. We expect that there must be dural tear, that you have intradural hemorrhage, mostly subarachnoid hemorrhage of the region. So our case, you can see that we have more of the eye symptoms, but you have also some of the neurological deficit. What I want to say is that if you have ophthalmoplegia, you have visual impairment, even blindness, don't tell the family and the patient that this will fully recover. Check whether all these cranial nerve, including the optic nerve, change since day one, since beginning. Because if the direct injury happened to the optic nerve and it's not related to the CC fistula, you don't promise that you're coming back to see everything clearly. No. But please make sure that the onset of these impairments start after you have, the red eyes and whatever the symptoms start later on. And what do? We do pre-treatment evaluation, of course. CT scan, usually enough. You can see the air or the fracture site at the carotid canal. This is very pathognomonic that you have carotid injury. And of course, the facial fracture that have high percentage of the related base skull injury. This patient with this and trauma everywhere with this pyovenous congestion, this can be seen enough for you to check non-contrast both window, brain, and contrast study to see the pyovenous reflux. And probably what I want to say here is that you check everything. You have fracture, you have exophthalmos, you have things. Usually, single one, you can check that the fistula should be on left side. But again, do you think you can use non-invasive imaging to check how many fistula you have, which side of fistula are there? This is the important things that you need to see, and I doubt that angiogram is still the answer for this. The location you can have from the very high, we call here our C1 location tear, to C2, probably there. C3, you can have inferior wall. You can have the precise part of the fistula to put embolic material. You can have C3 superior wall there. You can have even carotico-cavernous junction tear. So this is very precise, and you need to see where is it by looking mostly to the vertebral injection. Because no matter how many frames per second you increase, you will not be able to clearly see. There are people who rise into more than 6 frames per second, 9, 10 frames per second. It's not very useful ipsilateral carotid. Go for the collateral. Sometimes contralateral carotid can give some clue, but most of the time lateral vertebral artery is the crucial to look at the site of location. 3D angiogram is now very, very famous when you do angiogram, but again, you create quite an amount of radiation, but the younger generation prefer to make the 3D, and I'm fine with that. Of course, in this case, you will see precise location of the treatment, and you will see all the congested veins coming back to drain the brain now. This is the immediate venous phase that you should appreciate when you see this. Okay, how many fistulas are there? Where is it's right or left? Huh? You should be the larger one, should be the right side, that's all right, most of the time. But it could be drainage through the intercavernous venous part to congest, and also you have a severe, or even you have bilateral fistula with a smaller flow. Sometimes this is very difficult to see, and this is what we've got. You have on your right side fistula draining there, filling the contralateral cavernousness, becoming bilateral chemosis, and the malignant reflux from the contralateral side can be done. So this is an example that, just another side, there's no fistulas. Of course, the fistula point can be seen more clearly through the vertebral ejection, and this is what can be analyzed. So we recommend to do ipsilateral internal carotid, AP lateral, ipsilateral external carotid. Contralateral common carotid is fine. And the vertebral artery injection. If you have single plane, you can choose contralateral common carotid in AP and vertebral artery in lateral. That could be enough to see, for example, these associate injury to the external ipsilateral external carotid. You have another fistulas over there, and this is to see the possibility of being able to check the collateral, and this is to see the fistula and the collateral. So try to form in this successor angiogram if it's possible. And just example of CC fistula related with aneurysm, traumatic aneurysm related to the fistula. You can have this type of aneurysm related to the fistula. You can have dural traumatic shunt. You can have a lot of dissection all over the area. You can have this external carotid fistula at the same patient with SCC fistula. So be careful concerning one patient. You have bilateral CC fistula, you have bilateral external carotid fistula. This can easily happen, and you can overlook if you just go on with the ipsilateral. Some words about the treatment. Of course, we want to obliterate the fistula and we want to preserve the internal carotid if possible. So in my time, we were using a lot of detachable balloons. It's sad that I have a chance to talk with the Bout company, even to design a special shape, and they nicely put my name SP as the part of the size of the balloons, blah blah blah. But finally, this year the news comes that they will stop production of detachable balloons. It's sad, but sometimes commercial is commercial. Now you were able to put, this is exactly fistula coming down here, and you were able to use easily. Time-wise, procedural time, we were able to treat 1 cc fistula in average about 20-25 minutes from the last diagnostic round to be able to complete occlude compared to the newer device that I can show you later on. So sometimes if you need more than one detachable balloons or too many material, you know yourself that you may not be able to preserve the carotid. It's challenging for the first treatment. You design that your balloons should be there and the balloon is here following your design, and you can have a nice result. But most of the time, more than 2 detachable balloons, usually I cannot preserve the carotid. I come in the middle of the night because of number 1. But number 2 and number 3 clinical is making you urgent. Urgent meaning in few days, but epistaxis cannot wait overnight. So you come and usually don't try that much to preserve the artery. And you were able to sacrifice and close up the this bad situation. Sacrifice. Usually the indication are what I said, false aneurysm extend beyond cavernous sinus confine, both into the sphenoid and even rise up above the dural ring over the cavernous sinus and created chance of created hemorrhage in the open space. So, for example, this patient with this giant fistulas, you were trying to check everything, and now you're putting first balloon, second, third balloons, never stop. It's not stopping. But now we change policy to be able to sacrifice. So you make a shoulder. You use the previous balloon to make a shoulder at the fistula size to be able to place the sacrifice balloons. Because either that or the embolic material will keep on going into the pouch without being able to sacrifice. So the sacrifice means you need to make sure you cover distal to the fistula, at the fistula, and slightly proximal to the fistula, not counting the one at the cervical, that's a safety balloon. So this is the way that we are, the step of thinking about how we sacrifice nicely. Gigantic pouch, you know yourself, you will not be able to easily save. You try for the first time, there's a little remnant there, but everything moves. And then now you need to try yourself as much as possible to get the shoulder, be able to put all the sacrifice things there. You can have from this to this. In 3 months follow-up, the gigantic pouch becomes shrink and have a nice follow-up afterwards. Bypass is something that you should be able to talk with your neurosurgical team. And this is, again, from the team in Sri Lanka, that they will accidentally detach balloons and they will not be able to make the circulation into the brain. And the team was so nice that they do emergency bypass. Think about anatomical variation. This is this slide. I was trying my best to go with detachable balloons and it never go. So when I look carefully at the vertebral artery, this is a trigeminal artery, and by doing that, you're never able to go easily with the big detachable balloon. So now we changed the policy to put cords and others when we check this anatomy, and this is what we were able to go arterial, venous, whatever, to pack all this, keeping still the trigeminal artery that was shown after we were able to close the fistula. Alternate materials, whatever you have, that you can do, try first transarterial, if not transvenous. And transvenous, I will recommend you to go inflate torso to get cavernous, or look at the external jugular system to go facial ophthalmic veins. And this is the first case we were not able to put the balloons. Look at the 3 bump. So of course, one catheter can be placed there, and by that time, I was putting a catheter past the first pouch, and I was in the second pouch, be able to glue that nicely, and just leave the first pouch because you don't want reflux back into this. And the healing process of the tiny little pouch was very nice in follow-up. This can be done if you are mature in your injection of the embolic material. Look at this. The detachable loop is almost getting there, never. So we were not able to do that. So I will go by inflammatory pass into this cavernousness sinus. Like we treat dural eviction at cavernousness sinus, we were able to put all the base coils. There are no root, arterial root. This was clamp or was sacrificed before. And look at this. The only way is to go contralateral carotid and try to go inside, and that's what we do with the contralateral. We pass the A down and put all the embolic material that can close up the fistulas. Venous approach, as I told you, can be from inferior dorsal, but this also can be from this. So I recommend you not to close your field when you do this injection. Make sure you see all along down to the neck, because it is the root that can possibly be one of your chance to go in, because people cut it at the mandible, and it's I don't recommend. This is one of the root. We were able to go through with some difficulty, but finally we get into the pouch and be able to treat nicely. Direct percutaneous ophthalmic veins, I was doing this only for few cases, and to work with ophthalmologists to be able to control opening up this area of the eyes and do this puncture into getting at the cavernousness sinus, because there are no other route. Others are either clamp or ligated, and the recurrence was passing through the clit there. So you have no chance. You need to go into the only route available, and you can put the coils or whatever. In this case, I glue it nicely. Okay, this is how new generation love to do. They love to do this. And you see tiny little fistula that you have had time to use transarterial route. Again, you will look at the transvenous entry into this and be able to go with the coils. Final. The stent. This is a case that we see together with the team. And very rigid. Can you see how we need to put the guide wire far to be able to get any type of stent available now? Is stiff, and to go into the cavernous carotid. I can tell you, you can have a lot of experience by doing that, but in very selective case that you have no other choice, you need to preserve this carotid, and you have no available bypass surgeon, whatever. That's the only way that I would choose this. This is already shown to you spontaneous closure. Caution, minor trauma, CC fistula. This is a loss. And you know that with tiny little embolic material, it seems to be good, but look at the ugly looking type of artery without doing anything. This is 2 minutes later injection. The artery injury was, bad by that time. You have opened up the fistula and more injury to the carotid. Look at this, trying to follow up, and it's still bad. The balloon was there, there more injury to the breast. So finally, we will recommend you to close up this lateral case if possible. It will start from your puncture at the groin. Can you imagine? We lost one patient. It's the only patient we have the problem during puncture at the groin, because retroperitoneal hematoma can be very bad, because earlier loss is something that you need to be very careful in terms of treatment. This is an F1 with all these bad artery. Be careful. You can choose the less aggressive embolic material. And this is one point that treating this CC fistula, you were happy that you closed most of the fistula, but now from non-seeing this retrosal posterior fossa opening up, you change so-called benign only drainage out the eyes to so-called malignant reflux. Don't leave the patient. You need to go and finish the job. Even you have a better eye now, you have no more optic brain drainage. Don't leave that. So lastly, residual pouch. We were looking at our residual pouch during that 300 cases. The first one, by that time we have 6% of residual pouch. And nearly 50%, 45% are asymptomatic and not growing. And 57 are slowly clinically improved by that residual mesh pouch. Only 4.5% are the one that create symptoms. So that one, even we have known that this residual pouch can spontaneously close. But if you leave something like this and it's growing after treatment of CC fistula, you just bring the patient to treat as usual aneurysm. There is no problem with this treatment. So I'm saying that with this residual pouch, it's mostly not needed any further treatment, and the complications we borrow from other institute that you have ugly looking, high up above the dura, and don't put anything in the sac. Okay, they were doing not bad. They were putting materials, nice immediate post-op. But look at when you put the balloons too high into these dangerous pouch, it's few hours later, you can have this bad lethal hemorrhage. Go to the new version. I was reviewing last time, my first review is that you have small series. It's not 100% technical success. There are 50% approximately up to from spasm. Incomplete fistula closure up to 40%. Internal cardiac preservation is not 100% if you use a new version like stent. Need additional treatment 12%, not counting the cost effectiveness. I was looking for the last newer version of the publication. They have mentioned a lot of type of stent from graft stent, copper stent, some from the coronary one, and flow diverters. They still need several devices with multiple sessions. It is published like it. And immediate fistula closure is only up to 70%, it's not 100. Endoleak can be 30 to 40% up to. And it needs additional coils, stent, even sacrifice finally. So it takes months to close, and there are still residual neurological symptoms, and there are death reports related to the thing. So what I want to say, conclusion now, is that traumatic CC fistula is the most common in our place. Traumatic fistula, for me, even detachable balloon seems to be the most cost-effective, but sadly, I will need to change myself to use others. And I will come back and tell you in a few more years what is my favorite. Hopefully they can develop good enough stent that I can appreciate. So emergency condition is massive epistaxis, urgent condition is rapid visual loss and venous congestion. Thank you.